I am thankful to IAP Delhi and Sir Gangaram Hospital for giving this opportunity with you all. Pediatricians are more comfortable with hypoglycemia, diarrhea, infections, but treating cardiac disorders is slightly more difficult. If I recall 30 years back, an adult cardiologist used to say, बस इसका कुछ नहीं हो सकता है, in almost many lesions. But now pediatric cardiology has advanced a lot. It has advanced a lot.
Dr. Vipul?
I think problem from that end only. Maybe they're switching the device possibly. I have.
So, Dr. Neeraj, I'm really thankful for being here and chairing session, and it is always a pleasure to listen you. As Dr. Mittal was saying, that once upon a time, structural heart diseases were really very difficult thing even for us as a pediatric registrar. पास होने में सबसे ज़्यादा मुश्किल वही थी. So it was really difficult. People were not knowing about the disease, and more than that, they never knew that it can be treated also. So people like you, Dr. Neeraj, and many of us pediatric cardiologists, and the before us, the first generation of the pediatric cardiologists, starting from Dr. Rajan Tandon, Dr. Savitri Srivastava, Dr. Anita Saxena, Radha Krishnan, so Dr. K.K. Krishna Kumar. So everybody really worked hard to popularize the notion of getting the congenital heart disease getting treated. Not only that, the fetal medicine is also now evolving quite fast, and actually it will bring down the complex congenital heart disease and the disability level caused by the congenital heart disease. So pediatric arrhythmia, but is one thing which will never go down. Demand for its demand for the understanding, for the treatment, because every single entity can manifest eventually for the pediatric arrhythmia. For example, simply the electrolyte imbalance. For example, simple a viral illness. So pediatric arrhythmia is so important, and I am very happy that there are so many people are attending this particular seminar, and Dr. Neeraj is definitely a very, very good teacher. I have seen him evolving in front of me, and I am very proud of him. Thank you so much.
Thank you, ma'am. I will start the session because thank you very much, ma'am. I have grown under you, learning from you also, from Radha Krishnan sir also. And I'm really thankful to be in this branch. Actually, it's a exciting branch to be in. May not be with the money, but it's an exciting branch to be in. So let's start the session. This is the normal conduction pathway, and as we understand, all cardiac myocytes, they have electrical conduction and intrinsic mechanical activity. Each tissue has a different velocity and refractive period also. That's why, depending on autonomic change, circulating catecholamines, you would have different conduction velocities which will be changing. So this is important to know. There is a AV node which is higher, which is very slow in velocity. That's why you have a period between sinus node to from P to QRS. You have a PR interval because you have a node here, which has a low conduction velocity. That's why everything centers around this AV node to understand about the electrical pathways. Now, suppose you have a heart block here, the lower pathways will generate their velocity. So bundle of H, Purkinje fibers would have some intrinsic heart rate. The understanding is they would have lesser heart rate compared to atrial heart rate. That's why when you heart block, the heart rate goes down because the Purkinje fibers or bundle of His pathways are trying to generate the heartbeats. Now, trying to understand what is arrhythmia, we have to understand what is a sinus rhythm. What is a normal sinus rhythm? So this is a definition which says cardiac rhythm where depolarization of cardiac muscle begins at the sinus node. So for essentially sinus node has to generate a beat and that has to go to the lower system, and that's why you can call it a sinus rhythm. So as we understand in all medical colleges, we learn P followed by QRS is a sinus rhythm. So P followed by QRS is a sinus rhythm. But you understand this is not the complete definition. Suppose the atria is generating a beat which is not from sinus. Then P is followed by QRS still, but P is not generating from the sinus node. So that P followed by QRS cannot be the complete definition of sinus rhythm. This you all have to understand. So P wave axis and morphology is also important. P wave axis and morphology. If that is normal, then you can call it a sinus rhythm. So there are three characteristics: P followed by QRS, P wave axis has to be normal, and PR interval should be normal. So P wave axis, how do you remember normal P wave axis? When it's positive in lead 1 and 2 and AVF. 1, 2 and AVF should have a positive P wave. This is very important to understand arrhythmia. So P wave has to be positive in 1, 2 and AVF to call it sinus rhythm. So this single lead cannot be called as sinus rhythm. So when I see a monitor, I say, some people say sinus rhythm P wave followed by QRS sinus rhythm. No, it's not there. I have to see lead 1, lead 2, AVF also, and it has to be positive. Only then I can call it as sinus rhythm. This is very important actually. I will show in some examples. Now, when to call it a normal heart rate is age range. There are different criteria, different definitions. But what I remember in newborns, I say 220. In children, 180. And in bigger children, 6 to 14 years of age, average is around 100. So that's how you can remember 220, 180, and 100 in the older children, average rate. And then if it's above the normal limit for age, you are calling it a tachycardia. And if it's lower than the normal limit of age, you can call it bradycardia. Now, we have two types of arrhythmias here. One is tachy and one is brady. So, whenever you're analyzing a rhythm, you start with the heart rate. Exactly. Is it higher or lower? It's the first step. Tachy or brady. Because you're talking about tachy, then I will divide the tachyarrhythmia into two parts, narrow and wide QRS. And if I talk about bradyarrhythmias, I'm interested in blocks. What type of blocks are there? If time permits, I will go to the brady. I'm more focusing toward tachyarrhythmia today. Now, when I have a tachyarrhythmia in any case, that means my heart rate is more than normal. That means if newborn heart rate is more than 220, I am looking as tachyarrhythmias. And then I will divide the tachyarrhythmia in two parts, narrow or wide QRS. So narrow QRS or wide QRS is first step to decide whether I have tachyarrhythmia of narrow QRS type or wide QRS type. For all DNP students, this is mandatory. If I ask you what is wide QRS, you can't say SVT. SVT is narrow QRS. So you have to remember types of SVT you may forget. But SVT and VT you can't forget that this is wide QRS, this is narrow QRS. Essentially, this is the essence of defining the tachyarrhythmias. Then these arrhythmias, atrial flutter, fibrillation, atrial tachycardia, ectopic tachycardia, junction tachycardia, they are in the same group. Important to understand this group of arrhythmias, so SVT type, they will respond to adenosine. This type of arrhythmias, they will present as SVT, but they will not respond to adenosine. And wide QRS tachycardias will discuss separately. VT or VF or some type of SVT also can have wide QRS rhythms. Now, first thing is let us learn this ECG. On the left side, this ECG is, let's see whether it's sinus or not. First step is sinus or not. So P followed by QRS, yes, P followed by QRS. Every P is followed by, this is the P, this is the P, and every P is followed by QRS. So my one criteria is fixed here. every P is followed by QRS. Second criteria I told you, P wave positive in 1, 2 AVF. So 1, 2 AVF. That's how I have remembered in my whole of my residency and further course. If P is positive in 1, 2 and AVF, I am sinus. So P was P wave positive in 1, 2 AVF and P followed by QRS sinus. Now, this is the patient of tachyarrhythmia. See, the heart rate is very high. We're talking about a heart rate of around 250 or 300. So, when the heart rate is very high and QRS is narrow, QRS is not wide. So, then how I can call it a possibly a SVT and not a sinus rhythm, because I have a high heart rate and I have a narrow QRS and I can't find a PV also. Though some of the SVTs I will define where you can find a PV also. But for this staging, heart rate above normal and narrow QRS, I will call it SVT. So these are the criteria where I want to focus. SVT versus sinus rhythm. In an SVT patient, heart rate is mostly fixed, no beat to beat variability, and upper limit of infants is more than 220, children 180. So rate is higher than normal range. And in sinus rhythm, heart rate is in the normal range and beat to beat variability is mostly there. Sinus rhythm, if you have a high heart rates, they would have some beat to beat variability. With the fever, with the anxiety, with the stress, you would have a beat to beat variability. Now, P wave in sinus rhythm mostly present and normal. Normal means axis is normal. That means P is positive in 1, 2, and 8. Whereas in SVT, mostly absent or abnormal. Abnormal means if the P wave is not arising from sinus node, this is abnormal P wave morphology. Though P wave is there, but this is not sinus, this is SVT. I will give some example of this, which is very important to understand. Then in sinus rhythm, PR interval is normal and constant. But here, either you are not able to see the PR interval or it's very short. So P wave morphology is changing or PR interval is very short is also a criteria for arrhythmias. Then mostly SVT will have constant and in sinus is variable with wiggle tone. QRS complex, narrow QRS complex. We are talking about narrow versus wide QRS. Narrow 0.08 is the QRS duration, and or sometimes 0.10 is the milliseconds QRS complex narrow. Whereas sinus rhythm, you would have narrow rhythm, and QRS will be normal. So QRS duration would be normal in SVT and sinus rhythm both. So the most important point here would be heart rate is very high beyond age and P wave morphology has to be understood. Now this is an ECG. Let's see, focus on this part now. This is an ECG with the sinus rhythm. See, this P is every P is followed by QRS and same P is positive in 1, 2 and AVF. But in ectopic part, lead 2, focus this lead 2. I see the P wave is normal here, but I see the P wave is not normal. So intermittently P wave is going down, inverted P waves, and that's why we call it, this may not be a sinus rhythm, this may be some ectopic rhythm arising near the sinus node but not from the sinus. That's why they are called ectopic tachycardias. But they will also behave like SVT in a full form. This is again a case of post-op ICU. See the P wave, you have P followed by QRS, rate is not very high, but see the P wave in lead 3, negative, 2, negative, 1 is positive, and in AVF again, this is negative. So P wave morphology is also important along with P followed by QRS. In all these leads, P is followed by QRS. So this patient has used to have intermittent tachycardia, and when we saw the ECG, we found he has ectopic rhythm, not coming from the sinus. So these are also form of SVT, very commonly seen in pediatric practice. So what is the definition of SVT? All arrhythmias that either originate or incorporate supraventricular tissue above the bundle of fish. So I have a SA node, AV node, and then bundle of fish start. So this is the point, is the cutoff of the bundle of fish. So anything which is coming arising above the bundle of fish would be called as SVT. So this may arise from this part or from the junction part, from the AV node part. So these all parts will include a part of SVT. So anything which is arising above the bundle of H will classify for the supraventricular tachycardias. They may be flutter, they may be fibrillations, flutters, nodal pathways, ectopic rhythm, they all will come into the picture of SVT. So this is the classification of SVT based on site. This you may not remember all the facts, but remember if it's not fitting into that criteria of sinus node and it's narrow QRS, we're talking about supraventricular tachycardias. So there are basically two types of groups in base site or base site. One is atrial site. When the arrhythmia is arising, SVT is arising from the atria, that means remember an example of flutter or fibrillation. They arise from either right atrium or left atrium. This is the site of flutter, site of fibrillation. So some focus arises in the atria, which discharges continuously and causes tachycardia. But they will be narrow complex, always narrow complex. So flutter and fibrillation are classical example, and ectopic atrial tachycardia is also not uncommon. And a lot of cardiomyopathy patients are misdiagnosed because they have arrhythmias causing LV dysfunction, and ectopic atrial tachycardia are one of the misdiagnoses of SVT causing cardiomyopathies. And in case of AV site, atrioventricular site means re-entry tachycardias. That means there are circuits, either AV re-entrant or AV nodal. I will describe these two, but remember they are basically re-entrant tachycardias. Most common is this AV RT. I will give this few examples to make this simplify. But here on the slide, you have to understand atrial arrhythmias are arising in the atria without a re-entry. And these are arising in the AV pathways using the atrial ventricular pathways, and they have re-entry tachycardias. These re-entry tachycardias will respond to adenosine. These tachycardias will not respond to adenosine, that is atrial flutter, fibrillation, or ectopic tachycardias. And I will try to focus how to differentiate all these tachycardias. Now, let us understand the mechanism of SVT. This is very interesting. May not be useful practically, but really interesting to understand how the re-entry happens. These are the re-entrant tachycardias, which is called AV re-entry tachycardia, and N for node. That means AV node. This is AV node re-entry tachycardia. Means I will describe. So AV re-entrant tachycardias have accessory pathway between AV and atrial ventricles, whereas AV nodal pathways have accessory connection in the node itself. In terms of this other group is automatic tachycardia. That means they will not respond to adenosine, and they arise from ectopic foci, ectopic atrial foci. In the atria, there is focus which is discharging the connections, and that's why ectopic tachycardias happen. Multifocal or single focal or junction. This you don't need to define those multiple types. You have to understand if you can identify automaticity on ECG, that means you are talking about lethal type of tachycardias, and this type of tachycardias mostly respond to adenosine. This will not respond to adenosine, and some other drugs have to be given for this tachycardias. It's a difficult topic. We have a recording, and I assume the recording will be shared with all the DNB students after the lecture, because these are difficult topics, and you need 6 hours to understand the basics of arrhythmias unless you are well versed with this type of arrhythmias. So this is in brief to understand re-entry mechanism. This is not necessary to know, but interesting to know how does re-entry happens. So whenever you have a re-entry pathways, you have two distinct pathways. One is fast conduction pathway, one is slow conduction pathways, and they form a loop. And that's how re-entry happens. So most of times there is a block in one of the pathways, and that's why re-entry happens. How the block happens, I will tell you. So suppose you have this is the fast conduction pathway in the re-entry circuit. So when the fast conduction pathways have blocked because they have long refractory period. So once the impulse passes, they have long refractory period. The other impulse will not go rapidly here, it will go here to the slow conduction pathway. If this pathway has passed the one impulse, the other impulse will not come here, it has to pass through this. And when it passes through this, it will come back. And by the time it comes back, this has come into the, again become functional. So that's how circuit happens. So slow and fast recovery pathways make the circuits. So slow conduction pathway will pass through the to the muscle tissue, and it will come back to the past pathway. So, the wave of excitation from the premature beat arrives at the distal end of the fast conduction pathway, and therefore P wave will arise now. So, in any circuit, whenever re-entry circuit is happening, slow conduction pathway will allow the impulse to pass, and fast conduction pathway will be blocked. So that's how the loop happens. That's how slow conduction pathway to fast conduction pathway. And that's why P wave will be there either in the buried into QRS complex or after QRS complex. After QRS complex. After the QRS conduction has happened, P wave will arise. So now, so both re-entry circuits use the AV node. That's why, because adenosine works on AV node, that's why re-entry circuits get blocked with the adenosine, because they both of the types of either AV reentrant tachycardia or AV nodal reentrant tachycardia, both types of tachycardia will use AV node to conduct the circuit. So if you block the AV node, the circuit will block. That's how you get the response to the SVT. So in AVRT, accessory pathway is not in the node. Here, AV nodal pathways, AV node has slow and pass both. In AVRT, AV node and accessory pathway is there. In AVNRT, AV nodal reentrant tachycardia, slow and pass pathways coexist within AV node. This is also not to be understood by a pediatrics group, but for a cardiology, this is important in terms of ablation pathways. But remember, so AVRT has a pathway which is outside AV node. I will describe few more. Now both can have conduction pathways. Now this is the interesting part, or there are two types of conduction pathways. See, this is the accessory connection here, and this is the nodal connection here. So you have accessory pathway here, which is from atria to ventricle, and there is a AV node here. Now, now this has two types of circuit possible from atria to conduction. Either this goes through this way or this goes reverse way. That means if the P wave, P atrial pathway uses AV node to conduct and reverse pathway comes here, that will lead to narrow QRS complex, because you are using the AV node to conduct the accessory conduction. So if AV node is being used antigradely and back track is coming, retrograde is the accessory connection, then you have narrow QRS complex. But if reverse happens, that means the conduction happens from this to this directly through accessory conduction, then QRS will be wide. So in such scenario, where you have conduction happening through AV node, there will be P wave after QRS complex. So this is example. So this is the SVT patient. See, this is SVT patient. You can't recognize where the P waves. I zoom it, and most of the times P is seen after QRS complex. This is difficult to interpret, but sometimes you can see a P wave followed by QRS. See, in any SVT, P wave has to be there, either buried into QRS complex or after QRS complex. P wave atria has to contract. So when you say P wave is not seen, doesn't mean P wave is not seen. It means P wave is invisible. It is there but invisible. So here, see, the P wave is followed by QRS is followed by P wave. So P wave is retrogradely being conducted. Now here, I told you other pathway. So you don't know, remember, but remember the P is now conducting through the accessory conduction. The antegrade conduction is happening through the accessory pathway. When you go directly to accessory pathway, not using AV node to conduct to the ventricles, in such scenario, QRS will be wide. It will be wide QRS because it's not using the normal pathway. So SVT can have wide QRS pathway in such scenario. This is not a common phenomena, but in past, if you see in the past, they have said either it's a narrow complex or wide QRS, you may give a trial of adenosine, because you may have such type of SVT and which will respond to adenosine. So if adenosine, wide QRS complex and adenosine responsive, this is a test to say this SVT using the accessory pathway as a antegrade route. That's why these patients might have a wide QRS. Next ECG is coming, which will show you a SVT with wide QRS. See this. So tachycardia, wide QRS tachycardia, and you can't differentiate. But if you see closely, P is somewhere here. So you can see every QRS complex has a P, but it's not easy to differentiate. So in such cases, if you try a adenosine, this patient would respond. So with the experience, you know QRS is not that wide and child hemodynamic is stable. You may give a trial of adenosine because this is using an accessory conduction. And if you block the accessory conduction by the adenosine, that means you block the AV node by adenosine, the response may be there. This is very interesting to understand. Wide QRS tachycardias can be have a SVT basis and they will respond to adenosine. So similarly, AV nodal means node has both intrinsic pathways and they may have P, inverted P or merged P in the. So you don't need to differentiate AVNRT and AVRT in your practice, but it's slightly, sometimes it's feasible to have a differential diagnosis. They both will respond to the adenosine. Now, what is WPW? Wolff-Parkinson-White syndrome. It's a very exciting syndrome. This is again a type of SVT, again a type of SVT with wide QRS. Means accessory conduction is not happening through AV node, happening through the accessory pathway. That's why P wave is very close to QRS. P wave somewhere here. So short PR interval and some wideness. That's why it's called WPW syndrome. And you can see slurring of the wave. So short PR interval and delta wave. This is called delta wave. And slight wide QRS. And this will respond to adenosine. So see this. This is the ECG. You can see the P wave here and then slurring and QRS slightly wide. So P is very close to QRS, almost merging into this because accessory conduction pathway is very close to it. So you can see, sometimes if you understand this slurring, you have to understand slurring. The QRS slightly tilted, thoda teda QRS ho gaya hai, tilted and slurred, and P is very close to QRS. This will respond to adenosine. And second important part, excuse me, you should not give digoxin in such cases because they will become malignant VT. So digoxin is contraindicated, CCB is contraindicated, cash channel blocker. You should do adenosine and beta blockers on this patient. That's why in every SVT patient, it's important to rule out WPW syndrome. Another patient of WPW, P is very close to QRS, and see the slurring part. You can see the slurring part. If you zoom it, you can see the slurring part. And P are short. So if these patients are having intermittent palpitation episode and baseline ECG is showing this complex, you should not give digoxin to this child. You should give only beta blockers to this child. The other part, now this, I have tried to cover the re-entry pathways which will respond to adenosine. The other pathways, automaticity like fibrillation, flutter, ectopic tachycardias, they have, because SA node is not discharging, the other pathways are taking care in the atria, causing automaticity and causing arrhythmias. So what is ectopic tachycardia? This is basically non-reentrant tachycardia. See, the normal sinus wave is P is positive. In ectopic tachycardias, P is inverted in lead 1, 2 and AVF. This is important part to understand. Lot of this misdiagnosis of cardiomyopathy is happening in ectopic tachycardia. So they are narrow complex tachycardia with P waves abnormal in morphology. P waves abnormal, but every P is followed by QRS. They have abnormal P wave excess. That means simple to remember, 1, 2 and AVF P is inverted, and that will lead to understanding that this patient is not having SVT. This is the patient response to adenosine. Now let's see the response to adenosine. This is the patient of SVT. See, this patient has high heart rates, and sometimes I feel this is the P wave. This was the initial, when I was in the residency, I used to think that this is the P wave, but the rate is so high. So, and where is the T wave then? Then I started learning. My teacher told me, if you are seeing this is the P wave, where the T. So you have to document T and P separately. If tachycardia patient, you are not able to document T and P separately, that means this may not be a P wave. This may be a P wave, this may be a P wave, but you have to document both P and T in the complex when you're having a tachycardia which is out of proportion. So this patient has this wave, which I'm not sure P or T. Let's see, I gave adenosine. And when I gave adenosine, see this beats, all peer comes back. Normally, in a sinus tachycardia or some other SVT recurrent tachycardias, so all should go off. But here you see, all P is seen only. That means this P is at ectopic rhythm. Otherwise, everything should be blocked, or P should be followed by QRS. When you're seeing only P waves, that means this is SVT, and type of SVT is ectopic rhythm. The baseline rhythm is only P is generating the beats and QRS is not being conducted.
Dr. Neeraj, sorry to interrupt in between.
Sir,
Please spare some time for adenosine to be how it is used, doses. Please spare some time.
coming, sir. Next slide is coming. Let us divide the type of SVT and then come to the diagnosis. Sure, sir. So this is again PV morphology changing. See, the focus on the PV morphology has to be there to call it. No, this is not sinus rhythm. That my understanding is if P wave is morphology is changing, see, it's positive, negative, positive, negative. That means this is a ectopic rhythm. This is not a sinus rhythm. That is the message of this slide. I will skip this part for the time. Now we come to this part. So remember the flutter. This is again a non-reentry tachycardia, means they will not respond to adenosine. So if you see flutter waves, you are not trying the adenosine here. You have to give some other drug for flutter. Mostly sawtooth appearance, and normally they have weighted. Normally atrial rates are up to 500. So if you calculate atrial rate, they are very high, and ventricular rate is less than atrial. So this is the example of, this was a newborn, day 1, had SVT, and when we gave adenosine, this rhythm turns to this. See this P waves, sawtooth appearance of the P waves. You can see the P waves are in multiple, maybe around 400, 500 per minute. So these are the sawtooth appearance of the flutter waves. This is an interesting ECG for to understand. So this is the flutter. You can see the flutter waves. Now see this ECG. You have to first, this was a difficult ECG to understand for me in the beginning, but now you understand. See the QR, first localize the heart rate. I am touching the heart rate. QRS, QRS, QRS. So heart rate is low here, 5, 10, 15, 20, 20. So around, heart rate is around 60. Here heart rate is around 150. So heart rate 60 means I'm not talking about tachyarrhythmia, I'm talking about bradyarrhythmia. Now, when the heart rate is low, heart rate is around 50, 60, these P waves are seen in between. What is diagnosis? When you have low heart rate with multiple P waves and QRS interval is so far, this is heart block. So this is CHP and this is flutter. They look very similar, but we have to start with heart rate. Basics is starting with the heart rate. My heart rate here is this, and I mean in between we have P waves. So this is, sometimes you become confused when you talk about bradycardia, talk about heart rate, and then see that these are the P waves. So P waves are continuing as normal rate 150, 160. Ventricular rate is 60. But here P waves are at heart. P wave rate is, atrial rate is 500, 400. So when the P wave rate is 400, talking about flutter, otherwise CHP. Some clinical clues in reentrant tachycardia is very important to understand. In clinical clues, they are sudden, because they will respond to adenosine. So a patient coming with a sudden onset arrhythmias, exercise induced, mostly regular, and they will respond to vagal maneuver, then this is SVT. And type of SVT would be AVRT. That means he is mostly likely to respond to the adenosine. Fibrillation and flutter, they will not respond to adenosine. They're mostly paroxysmal and they have irregularity. Now we'll come to the some part of white QRS tachycardia, and then we'll come to the type of adenosine, how to give. So how to define VT? When you have series of 3 or more PVCs called VT. White QRS more than 3, otherwise less than 3 is PVC. Less than 3 beats means PVC. But together, if you have series of more than 3, this is VT. This ECG. See this ECG? White QRS classically white QRS, and you can't identify PVS here, and continuously white QRS complex. So this is a VT. Causes of VT, one is focus is in the ventricular myocardium causing white QRS. The other is WPW. I told you, when accessory contraction is happening through the accessory pathways, not through the AV node, this will lead to widening of QRS, short PR interval. And third, if you have some bundle branch block, you may have white QRS. This is not a common thing in our practice. Remember WPW and VT. So broad complex tachycardia is VT or SVT with WPW syndrome. Broad complex tachycardia is VT unless proven otherwise. So you treat it as a VT unless proven otherwise, but you can try adenosine in all VTs if they are hemodynamically stable. That is past guidance. Now see this white QRS tachycardia. This is monomorphic. All morphology is same, but here morphology is changing. The axis is changing. The bigger complex, then smaller complex, bigger complex, smaller complex. This VT is called torsades, and this is classical example of hypomagnesemia or long QT syndrome. So calcium and magnesium are important. When you see this type of VT, where your axis is changing, you're talking about supplementing magnesium and calcium, and here you are talking mostly about lidocaine amyotrophy. This patient, interesting in the practice, I saw it 5-7 years back. Patient had recurrent episode of syncope. I sent him for the ECG, and this was the ECG, and you can see the ECG having torsades, bigger complexes and then smaller complexes, and again bigger complexes. The twisting of the axis of the VT. So this is called torsades, and he reverted spontaneously in the ECG room. And see the ECG now, a narrow QRS complex, but QTC interval is prolonged. So any VT patient, look for QTC interval. How to see QTC interval, I will cover in some other class. But remember, in all patients of VT, QTC interval has to be seen. So long QT syndrome is a very common cause of VT in our pediatric practice. Especially when you see this type of VT where axis is changing, start thinking of long QT syndrome. On a monitor, see this is the QRS complex, and I see the T wave is very far from QRS. So when T wave is very far from QRS complex, crossing almost half of QRR interval, then start suspecting QTC interval, long QT syndrome. So this is the patient of long QT syndrome we saw diagnosed on the monitor only. And long QT syndrome, you have to give calcium and magnesium. Most of the patient will respond. Now, the problem is, most common problem is patient has history of palpitation, and he would come to you with that I had a palpitation, but right now ECG is normal. Because by the time it comes to you, the episode is gone. So you are not sure what is happening. In such scenarios, Holter may help, 40 hours Holter, because child is going to SVT recurrently, and Holter may pick up the diagnosis of SVT, but not always, not always. Now, so I'm trying to give in 3 slides the approach to tachycardia. When you see tachycardia, go for narrow complex or wide complex tachycardia first thing. How to define narrow wide? Approximately 80 to 100 milliseconds. That means 2.5 squares, 2.5 small squares on ECG. That means that is narrow. If it's going more than 2.5 squares, this is wide QRS. That means 100 milliseconds. One is 0.04 milliseconds. So 2.5 horizontal small squares is small complex versus large complex. That is the cutoff. 2.5 small squares. So if I define narrow QRS and wide QRS, then wide QRS is VT or some SVT with aberrant conduction, that means WPW. And narrow QRS means is happening mostly via the AV node, conduction happening to the AV. That means SVT most likely. Now, if I have a narrow complex tachycardia, I want to see regular or irregular RR interval. If I have a irregular RR interval, classical teaching in all pediatric examples is fibrillation or flutter. And if regular interval, I am going to further, but I'm saying this is SVT, and I have to define the type of SVT now. So I have divided narrow wide QRS, narrow QRS, regular or irregular. Irregular, I'm talking about flutter fibrillation, and regular, I'm coming ahead. So if I have a regular narrow complex tachycardia, I'm saying this is SVT. Narrow, regular complex tachycardia, I have ruled out wide QRS VT. I'm coming to this now, and I have ruled out irregular type of SVT, that means flutter or fibrillation. Now I have come to the, can I see the P waves or can I not see the P waves? If I can see the P waves, then some tachycardia, flutter are possible here. If I'm not able to see the P waves, I'm talking about some type of reentrant tachycardia. Maybe AVNRT, most of the time AVNRT. So one more chart. Again, if I have seen regular tachycardia, I'm talking about narrow QRS, focusing on the SVT here. Narrow QRS tachycardia, regular or irregular, irregular flutter fibrillation, regular visible P waves, no, then AVNRT. If visible, then I'm talking about some types of RT and atrial. So P waves are seen, I'm talking about some type of ectopic tachycardia or atypical form of SVT when I'm seeing the P waves. If P waves are not visible, mostly nodal pathways, so it will respond to adenosine. If P waves are not visible, then I'm talking about flutter fibrillation. If regular heart rate, flutter, irregular heart rate, fibrillation, acute management. Now I will come to the management part. So once I have identified this look like an SV to me, tachycardia is there and it's narrow complex tachycardia. I want bigger children, vagal maneuver can be planned. Otherwise, adenosine should be given. Mostly, a lot of people want to give adenosine. If there is no response, if there is no response to adenosine, you have to go to next line. Most sometimes amiodarone. Resistant case of adenosine, most of the time amiodarone is a preferable drug. Dose of adenosine is 0.1 mg per kg, and if not response, then 0.2 mg per kg. Maximum in single dose you can give 6 and 12 mg. So 0.1 mg per kg, 0.2 mg per kg, and 0.3 mg per kg. You can give 3 doses. IV site as close to the heart, so center line or in the upper limbs, not in the lower limbs. Rapid flush technique, I will describe this by video, how to give rapid flush and monitor the ECG and BP. Amiodarone can be used in resistant cases of, which is recurrent or resistant case of adenosine as a bolus. How do you give amiodarone? You can read in the books, everywhere road is written, but remember the bolus dose is 5 mg per kg over 30 minutes. Bolus 5 mg per kg for 30 minutes, and then infusion doses. So when you give a bolus of amiodarone, always supplement it with infusion. And when you give an adenosine, I will discuss after adenosine if the rhythm will revert or not, what to do. So if you have given an adenosine, there are multiple pathways possible. One is no change in heart rate, give a more dose, and or consider this is not a VT, some other type of SVT. And then if IV adenosine has sudden termination, that commonly happens, you're talking about recurrent pathways. That means re-entry pathways. And there's no response to adenosine. You're talking about inadequate dose or delivery system, or you're talking about a VT. Or then irregular heart rate, you're talking about flutter or fibrillation. So when you give an adenosine, this type of response is possible. I have given the adenosine here, and I see most of the times, which are the commonest form of SVTs are re-entry tachycardias. This is the response you will see. The P and followed by QRS, P followed by QRS. If you achieve this time, that means sinus rhythm has arrived. Now, after you have given adenosine, you have to understand what is the chronic therapy, because this will recur. This will recur. After that, you have to start either a long-term drug. Maybe beta blocker is the first line drug I use. Sometimes in resistant cases, you can give amiodarone. But if the response is like this, you have achieved sinus rhythm, continue with beta blockers here. Maybe oral or IV, depending on situation. But beta blocker has to be supplemented after adenosine so that it prevents the recurrence. Adenosine alone will not help. Adenosine has a very short half-life, it will not help.
Dr. Neeraj, how long it has to be supplemented?
So
6 months, 3 months?
that will depend like a Caesar, like, and how long anticonvulsants to be continued. That will depend on that pathway. So suppose this is recurrent, you're continuing for 2-3 years. If it's not recurrent, maybe in 1 year down the line, you reassess and consider stopping. But most of the times, one SVT has happened, 1 year is the minimum time you are giving beta blockers. Then
Okay.
depending on 1 year protocol, like remember the SVT like a Caesar. So I tell everyone,
Okay.
remember like a
Yes.
Caesar. But single drug will not help. Adenosine like midazolam for a Caesar. You can't say that I have given midazolam, seizure is aborted, and child is cured. You have to start anti-epileptic, so you have to start long-term anti-arrhythmic.
This is a very common mistake that people make.
Yes, sir. Yes, I have seen this. That's why I came to this point. And understanding the seizures is very interesting to understand. So this is again a seizure in the heart. Any arrhythmia is like a seizure in the heart. So remember a seizure patient. Now this is another response of adenosine. When you give adenosine, see the P waves are persisting. This patient is critical because you have not achieved sinus rhythm. You are going in the ectopic pathways. And this patient has to be referred to the pediatric cardio as early as possible. So this will become cardiomyopathy if you don't treat it properly. This is ectopic tachycardias because you can see after adenosine, the P waves are persisting. Now, this is a common response to re-entrant tachycardia with SVT. The adenosine given here, and you see the sinus rhythm achieved. यहाँ पर आपको बीटा ब्लॉकर देना है. Now, this is a patient of came to me in the long time back in the OPD. I run this. Oh, 1 second. Now, okay, now it will be seen. So this is the patient of SVT around 1-year-old child. Hemodynamic is stable. I am trying to give adenosine in the ICU. So this patient has a monitor. This patient was seen in the OPD. I saw the patient. Echo was okay, function was okay. He had SVT. I have put a cannula. See, the cannula was put by my resident at 24. This is the first mistake. Small cannula. You should have bigger cannula because adenosine has a very short half-life. So you should have at least upper limb is used and bigger. I would like the brachial vein here, not the radial, and bigger cannula, or at least 22 or 20. But in smaller child, 22 would do. This patient was given 24 in the later distal part of the palm. So we are two people. There are three ways connected. One has adenosine and one has a flush. So monitor is connected because I want to record the ECG. I want to see what is happening. So that will decide my further course. So whenever you are giving adenosine in your practice, anywhere, ask one colleague to record the monitor if you don't have ECG. What is happening with the adenosine? That is a big clue for us to manage further. The adenosine is going. Now someone is recording the monitor. Let's see. Let's focus on the monitor here. Let's focus on the monitor. And see this now. What has happened? Three-way and push. So you give adenosine 0.1 mg per kg and suddenly rapidly you have to give a push, saline flush of 10 ml from the other port. Two people should be there. One is to push adenosine, the other one push the saline. And see now the them has blocked. And see the P followed by QRS. So that is tachycardia of re-entry tachycardia. Such a good response. There is no P wave in between. Every P is followed by QRS. That means I have achieved the sinus rhythm. So this patient has SVT. I have achieved. Now this patient should not go home. 24 hours monitoring because like a seizure, it may recur. So I have to start now anti-epileptic. That means I have to start anti-arrhythmic here. What anti-arrhythmic? Safer to start beta blocker. What beta blocker? IV or oral. You can IV is available is esmolol or metoprolol. Oral is available is propanol. So if this child is stable, I would give this patient propanol oral because this child is hemodynamically stable, responded to single dose of adenosine, not a resistant SVT. I will give him oral beta blocker and keep him in the monitor. I will give a higher dose, 3 mg per kg, 2 to 3 mg per kg per day, not 1 mg per kg per day. Now, if suppose this child doesn't respond to single drug, I have to give 3 doses of adenosine. That means this is not a simple case. I would like to give him IV beta blocker. I will start metoprolol, IV metoprolol, or if not respond to 3 doses of adenosine, I will start IV amiodarone. And if no response to IV amiodarone in next 24 hours, I am going for a cardioversion. I am going for a DC cardioversion. This concept you have to understand. So most of the time, SVT is well tolerated. They will not crash rapidly. So if you are giving amiodarone, one more concept is there. Suppose adenosine response is not there, 3 doses you have given. You have started amiodarone. After 6 hours, you may again try a dose of adenosine. And this time, under amiodarone influence, adenosine may work. So this is also a concept. But see this now. So I have achieved the rate control. Now I'm recording this. I want to see whether it's recurring or not. So I have achieved the sinus rhythm here. So I'm comfortable managing this patient, that this patient will go on a beta blocker. I have started oral beta blocker on this patient, and I will wait for 1 to 2 years for the arrhythmia-free interval. And then let's say take a call. That should leave it to the pediatric cardio for the future course. Now this patient, another patient of adenosine. See, this patient has SVT. This was thalassemia major, hematoma borderline, and we give adenosine. And see the after adenosine, you see the P waves here. You see, all can see the P waves. So here I am seeing P waves, multiple. So this is not a reentrant tachycardia. This patient should be referred to a pediatric cardio as early as possible. This diagnosis is ectopic atrial tachycardia causing SVT. And this patient need specialized therapy. This patient I gave ivabradine. Ivabradine is a good drug because they are reduce the automaticity. After 48 hours of ivabradine, see the sinus rhythm is achieved. You can see the P followed by QRS, normal axis. So this patient has complete response, but this patient will respond to specific treatment. So in cases of any patient who is giving this, you are giving adenosine, as early as possible, you should take opinion from pediatric cardio. But if it's not possible, these patients who have ectopic rhythms should be definitely going to the peds cardio. So SVT management on a maintenance therapy. That means we are talking about chronic maintenance. We have given adenosine, control the rhythm. Now I want to start beta blocker. Esmolol IV is available. Metoprolol IV is available. These are oral drugs. Then if they not respond, what we use flecainide or amiodarone in our practice. Amiodarone you can also start loading and then refer these patients to the pediatric cardio centers. They have potent half-life, long half-life. Remember the amiodarone has toxic drug. They may have retinopathy, thyroid dysfunction, pulmonary fibrosis, liver issues. So amiodarone is a toxic drug. I don't continue it for more than 3 months. Then again, I switch over from amiodarone to beta blockers after 3 months if I have to give amiodarone any patient. So my role is acute therapy, IV adenosine, and then amiodarone maybe, and then switch over to beta blocker in first 3 months. The chronic management is difficult slide. Only message of this slide is you have to give prophylactic medications, beta blockers for long term, and if child is more than 15 kg, you're talking about radio frequency ablation in the cath. In the smaller children, the risks are very high. If your child is less than 15 kg and you're not able to manage the arrhythmia on long-term therapy, then you have to go for radio frequency ablation. We have done radio frequency in our unit at as age of around 3 years, but we don't want to do this unless we are forced. So most of the times, less than 15 kg, you give 2 drugs or 3 drugs, try to achieve the 15 kg weight, then come for EP. EP study means same radio frequency ablation. So you go for EP study and ablate the pathways basically. So more than 15 kg is easy. Less than 15 kg by Heart Rhythm Society, you should try to manage by beta blocker drugs. Some patients say like a single episode of SVT, you may not give any drug. Like a single episode seizure, you may not give antiarrhythmic, but history-wise, you can assess if the child is having frequent history of palpitations, past history, you should start on a long-term therapy. So first line drug is beta blocker. Infants, I give propanol. Older children, I give eternol. Digoxin is reasonable alternative. We try to avoid nowadays. Beta blocker is safe drug, less side effects. Poor response to monotherapy means you have started beta blockers and child is not responding. More than 15 kg, go for radio frequency ablation in the cath lab, EP study basically, and ablate the pathway. In smaller children, you try with second line drug. You leave it to the pediatric cardiologist. If you're not able to manage the drug with single drug, you should try flecainide amiodarone. Normally, I try flecainide and amiodarone. Sotalol is not commonly used in our unit. And RFA has a radio frequency ablation. EP study has a high risk of morbidity in the smaller children. So points to remember for SVT, digoxin should never be given in presence of WBW. The first line therapy is beta blocker, and you have to give most of the times, don't, as Dr. Mittal says, people don't give long-term therapy. You give adenosine, start beta blocker, and then refer to the pediatric cardio. Teach parents to take the pulse, Use a pulse oximeter at home and vagal maneuvers to be taught to the parents. This is useful in bigger children, especially. Take home message: SVT mechanics are mostly re-entry tachycardias, responsive to adenosine, and PV morphology will tell you about automaticity. ECG should be able to differentiate narrow versus wide QRS complex tachycardias. Any broad complex tachycardia is VT unless otherwise. If there is a hemodynamic compromise, give cardioversion. In any case, SVT or VT, compromise means you give cardioversion. Adenosine is first choice in all AV nodal dependent SVT. Even in wide QRS, you can try an adenosine. One more point I want to highlight in the last slide. This is a case report. This I saw this child long time back, and this patient had cardiac arrhythmias because of diverticuli in the atria. This patient had cardiac anomaly causing asphyxia, not a common anomaly, but what I'm trying to say, always get an echo done to rule out any diverticuli. I reported this case long time back. This child was diagnosed as asphyxia as a newborn, continued our therapy for 5 years. Then he came to us and we did the echo and found the diverticuli. And diverticuli were the focus of the incessant neutral arrhythmia. So this is an important understanding that echo should be done in all such cases of arrhythmias, not only ECG, to rule out structural malformations, which are not common in the pediatric age group, but possible. Thank you for this. I think I will not cover the second part. I have some exercise also, but I will try to skip this. I think the arrhythmias have to be given more space, more time to learn, and it's difficult to remember in 1 hour. I would request all the DNB students to get this video and revise these slides. Thank you, sir. Thank you very much.
Uh,
Dr. Neeraj, am I audible?
Yes, sir. Yes, sir.
Do you have any classes like ECG reading or some training, or madam
Yes, sir.
has something like that for these
Ma'am
DNB
has lot of
residents?
ma'am has lot of material, and we
Mhm,
also have lot of material. We have done workshops also. So
mhm,
6 hours workshops are possible in any center. If you say we'll do in Sonipat also, sir, 6 hours time is needed actually. So that time is needed. 6 hours. We have slides. We have ECG also. We give ECGs to the audience for the participation to read. So basics to advanced you can do. Smita Mishra ma'am has lot of slides actually. She has done a lot of workshops also on the ECG.
mhm.
Ma'am.
like ECG is one thing, and like any other practice, like and in your practice, if you are regularly giving IV fluid in particular electrolytes and all those things, so you learn that. And ECG also needs that kind of practice, that and every single baby in the PICU and ICU should have one ECG, and it should be read properly. And if it is a habit, then probably you just befriend the PQRST, these waves. Once you know what is the normal, then you can definitely make out what is abnormal. And what Dr. Neeraj said, that there is a limit where, like for this SVT, where you're giving adenosine and you are looking at reversal, but after that, a echocardiography and the detailed rhythm pattern needs to be seen by the cardiologist, and so many time electrophysiologist also. We also take help of the electrophysiologist. And the thing is, we have seen many patients. I think Neeraj will agree with me that many patients who were waved off like a case of dilated cardiomyopathy, if you go and you see the this ECG very closely, one fine day you find one SVT happening over there. So, at least two cases of mine where I was actually thinking what is happening to these patients, and after say 3 months or 6 months, I picked up that it was actually SVT, because it happened in front of my eyes while I was doing the echo or something. These patients were given Holter monitoring also, but in Holter monitoring, it was never picked up. So many times, these intermittent episode of uh, and SVTs or maybe VTs or different type, whatever, these rhythm disorder may cause really tachycardia induced cardiomyopathy, which is very, very treatable. And I am so happy to tell you that at least 4 or 5 patients of mine, they were actually tachycardia induced cardiomyopathy. They were actually on follow up from different big institution, even from the AIMS, and they subsequently were treated with the antiarrhythmics, and one of them went for the radiofrequency ablation, and all of them responded very well, and the ejection fraction was restored. So tachycardia, as Dr. Neeraj said, on and every time, like, this is very important that we must know what is the basic. ECG is also important, like this is the arrhythmia, but also for the electrolytes. It's such a simple way. And this for the structural heart disease, even when you are having no echocardiography around, if a very drastically abnormal QRS axis or very drastically abnormal P axis or T axis, one can always suspect at least 80% cases correctly that there is some serious structural heart disease. So electrocardiogram is very important in my view. Also, as Dr. Neeraj said. Hi, Dr. Alok Bhandari,
Uh,
Honorable President of Delhi IAP. Welcome, sir.
no, no, I
Your
was there
comments.
for quite
Good
because
evening.
I came to know Dr. Mittal had difficulty in logging in. So then I came for troubleshooting, but by then he had already logged in through his phone, not the iPad. And
Yes,
Dr.
I
Anupam
managed.
Singh also and Dr. Anupam Singh also had an issue with logging in, and but now we are going for this correction, and I think by the next session this will be corrected, and everybody will be
Good.
able to log in conveniently. And I beg your pardon for this lapse from the technical lapse, you can say, at
No
this
problem,
time.
sir. These things does happen.
Uh,
This is electronics. Madam,
and
my one question to both of you. This radiofrequency ablation is a one-time procedure or sometimes we have to repeat it? And how much it costs?
So first I will give Dr. Neeraj because he is the speaker today. So please answer Dr. Neeraj, then I make comment. Hello, Dr. Neeraj? So yes, radio frequency ablation is 98% success rate. In 1 or 2%, there might be some issues. These issues include the complete destruction of AV conduction, and you may land up in the complete heart block. That is the reason why the usually electrophysiologists, they don't want to actually intervene in the smaller kids, because the space is
Mm.
less, and they may definitely have a major complication. That is one. And in 1 to 2% cases, it may I mean, it may not be very successful. You are not able to hit the proper place, or I don't know if it is renervated kind of thing. So this is what here. And the expenditure is different for the all hospitals and the kind of technology they are using. So this is something between the 2 lakhs, 2.5 lakhs onwards, whatever.
Okay, okay, ma'am.
So
Okay, ma'am.
now 3D, this thing, they are using the very, very advanced. In my one of my case, which I got that case from Agra, patient presented with 10% ejection fraction, and landed. Then I was working with the Fortis escorts. Midnight I got that patient. So heart rate was around 225, and it was just kind of PQRST was fine. So I thought, okay, fine. If I reduce the rate around say 150, then probably cardiac output will be little better. So taking the challenge, I sat there overnight and I started metoprolol and I reduced the rate up to 150. In that particular case, slowly patient recovered, but I also referred that case to electrophysiologist to just look at this part, because patient improved with the metoprolol. We did this Holter monitoring. We didn't get any evidence of supraventricular tachycardia or any kind of tachycardia. So this patient slowly recovered and got the ejection fraction of 60% over the period of time. Then subsequently, suddenly, he turned up again with the 10% ejection fraction. It happened twice. Then I was doing echo, and suddenly the heart rate jumped up to 200. And then it was very clear in front of me that it was SVT happening. Immediately I went for a ECG, and ECG revealed that yes, it was SVT. Then this patient was put on the anti-arrhythmic drug, amiodarone actually, and patient recovered and went up to 60% ejection fraction at the age of 4 years. Then patient went for a some abnormal kind of SVT was there, so this patient went for a 3D assisted this
Ablation.
RF ablation, yeah, RF ablation at the 4 years of age.
Mhm.
And patient is absolutely fine now. Ejection fraction is 60 to 65%, no episode of SVT. So this is 100% result for this patient. So
Mhm.
that is how it varies.
Mm. Pediatric cardiology has advanced a lot, much more than other specialties.
Yes, sir.
Yes.
That is true.
Mm.
So this is more mechanical. Actually, I tell that we are more of kind of carpenters and plumbers rather than being a doctor or hemodynamics, like fluid dynamics, what you learn in engineering. So we are more of engineers than the doctors, I think. Dr. Neeraj, your comment? You open the valve, you close the walls, defect.
Dr. Neeraj is always cool and calm.
Mm.
It's called mathematics for me. 1 plus 1 is always 2. In pediatric
Yeah,
cardiology, most of the
exactly.
time. For me, pediatric cardiology is mathematics. 1 plus 1
Yes,
is 2.
exactly.
It's
That is
normally
more
matches
like
there.
a mathematics, less spiritual. You mean to say that heart is less spiritual? It's more more mechanical?
I have a lot of experience of working with Dr. Neeraj.
Yeah,
He's such a calm and mathematical person that
right.
things become so easy when he comes into picture in between.
No, he is a really great human
Yes.
and great teacher.
Yes, sir. Yes, sir. No,
डॉक्टर आलोक डॉक्टर आलोक भंडारी सर
हाँ जी सर, हाँ जी। तो
इसमें कोई
ठीक है,
ऑडियंस
उनको
जो
जब
जो जो स्टूडेंट्स है कैन दे आस्क सम
sir,
क्वेश्चंस और नॉट
actually, I have worked with you.
Yes,
I have
definitely, but
experience
there
with
are
you,
no
not
questions.
otherwise. I have experience of
ओके
working with you.
ओके
From my
ओके
younger days, I've been working with you, sir. Sir. Yes.
well, I think we can close the session now. It was a nice discussion.